Welcome back to the Health Diary podcast, where we have real conversations that help you better understand your health and make more informed decisions about your body. Today, we're talking about something many of us experience at some point, medical scans. MRIs, CT scans, ultrasounds, x-rays. We often see them as the key to finding answers, but do we always need them? And can scans sometimes create more worry, confusion, or even lead to treatment that may not actually be necessary? If you've ever wondered, why won't my doctor send me for an MRI? Should I get a scan just to be safe? Or how do doctors decide which scan is right? Well, my guest today, Dr. Rahil Kassamali, a highly experienced consultant interventional radiologist, will break down the facts clearly and help you understand which scans are appropriate, when they're necessary, and when they may not be. With his expertise, Dr. Rahil will give you the clarity and confidence to make informed decisions about your health. Dr. Rahil studied medicine at the University of Birmingham in the UK, where he also completed his radiology training before undertaking an advanced fellowship at Alfred Health in Melbourne, Australia. He holds both the fellowship of the Royal College of Radiologists and the European Board of Interventional Radiology. Before moving to Qatar, he worked as a consultant at University Hospitals Birmingham in the UK. Dr. Rahil has published extensively in peer-reviewed journals, contributed as a peer reviewer, and regularly lectures at international conferences. But what makes his expertise especially valuable for today's conversation is that as an interventional radiologist, he doesn't just interpret scans, he also uses advanced imaging to perform surgical procedures and targeted treatments throughout the body, from image-guided biopsies and pain procedures to vascular treatments and tumour interventions. Alongside his clinical and research work, Dr. Rahil is also a senior lecturer at Aston University Birmingham in the UK, with a strong passion for educating and helping both patients and clinicians better understand the evolving role of imaging in healthcare. So today we're unpacking what scans can and can't really tell us, when they're helpful and when they're not, and how to avoid unnecessary fear when it comes to imaging and diagnosis. If you've ever wondered whether you really need that scan, what it shows, or which type of scan is right for you, Dr. Rahil is here to clear up that confusion. I'm Shyla, stay with me, because after this episode, you'll walk away informed, reassured, and empowered about scans and your health. Good morning, Dr. Rahil. Welcome to the Health Diary podcast. Thank you so much for taking time out to be here. I'm really excited to learn from you and extract all your knowledge in this area.
Good morning. Thank you so much for having me on the pod. I'm really excited to be here, and we're talking about a topic that I'm really passionate about as well, but also something that's not talked about that much on health podcasts or for patients. So I'm happy to answer all your questions and give as much value to your audience as possible.
Amazing. Thank you. Okay, so let's get straight to it. Dr. Rahil, what exactly is medical imaging and what role does it play in healthcare?
Okay, so medical imaging is an opportunity for a doctor to take a look inside a patient's body and find out what is going on without carrying out a surgical procedure. Now, most adults that I come across would have had some kind of image investigation, and that could be an X-ray, a CT scan, an ultrasound scan, an MRI scan, or even some of the new age nuclear imaging scans like PET scans you may have heard of. And essentially it's when a doctor is trying to identify a diagnosis or answer a question through all of these different types of imaging.
Okay, and how do doctors decide whether someone needs imaging?
Yeah, so ideally, what you want is to be answering a question. And I always say to my trainees, for example, that the foundation of medicine starts with the history and examination and not with a scan. So a scan should be answering a question rather than we'll just get a scan, because the availability of having medical imaging now, for example, an X-ray or CT, is increasing. But what we want is for it to be directing patient care rather than causing more stress and anxiety and not as an unnecessary scan.
So in the UK, I was an advanced physiotherapist practitioner, and part of my role was requesting different musculoskeletal scans and imaging. And I understand the different types of imaging from that perspective. So, for example, an X-ray will be good for kind of bone diagnosis, and MRIs are better for soft tissue structures and diagnosis. But from your clinical broader experience across a wider range of conditions, can you explain to the listeners between scans like the MRI, CTs and X-rays, like what's the difference?
Okay, sure. So if we start right at the basics, so the first scan we'll talk about is just an X-ray, or we call it a plain film X-ray, which is a 2D image off your body, and it's most used for bones. The most common scenario would be someone's had an injury, they may have fallen over or had a sports injury, maybe worried about a fracture, and this is excellent for looking at bone, but not so good for looking at things like tendons or muscles. The other time where most of us in Qatar would have had an X-ray is a chest X-ray to look for an overriding problem that they may have before coming into the country as a health check. Now, with X-rays, these are very safe, very fast, often quite cheap to carry out as well. And most people that I come across would have had an X-ray at some point in their life. And there is a very small dose of radiation that comes with it, but that dose of radiation is negligible and shouldn't be worried about as a single X-ray that's carried out. So that's normally the first step in medical imaging. Then from X-ray, a lot of people would have had something called ultrasound. I know that, for example, when we had a child, when my wife was pregnant, she went to have a series of ultrasounds to look and identify the size or age of the baby at that time. Ultrasound is a very safe imaging procedure, is becoming much more common in clinical practice in the hospital because of the portability of this. And this is where you get a live image through sound or sonar. Now, sonar, some people know this because submarines communicate via sonar, but it's using this energy to go into the body and then come out to produce an image.
Okay.
And the advantage of ultrasound is it's like a live video image, so you can see exactly what's going on. In baby scans, they might say the baby's moving. In blood vessels, you can see the blood flow in certain areas. And in your case, where you work in musculoskeletal imaging, you can do a scan while moving the joint or moving your arm or leg or something at the same time.
Do you call that dynamic?
Yeah, so exactly, a dynamic ultrasound. And then you can see whether, for example, in a shoulder, if a tendon is impinging, you can move the arm and then see whether there's a pressure on that area, which you can't do on a still image.
So that's interesting, because when we had athletes that would come in with like a groin strain, with Gilmore's groin or a groin strain, you only have pain upon movement, like jumping and things like that. So we would do we would request for a dynamic ultrasound. So that makes sense.
Yes, exactly. Okay. So that's a big advantage of ultrasound, because it's dynamic.
Yeah.
There's no radiation, and it's very easily available. And nowadays you can get an ultrasound probe that could be attached to your mobile phone. So I could actually just, for example, bring it here and do a scan, and it's very easy to do that, and that's becoming more and more common.
Can anyone get this?
Yeah, and the way I see it in the future is the stethoscope of the doctor in 10 to 15 years' time will just be an ultrasound that doctors have on the ward. That's where I see that going.
Okay, so which is the most sensitive scan then? So is it an MRI?
So this is the perception that a more complex scan is better for the patient. Yeah. But that's not actually true. We say that different scans are better for looking at different things. So we spoke about X-ray, we spoke about ultrasound. Another scan that's commonly carried out is CT, which gives you a 3D image of the body. And then MRI, which is considered the most advanced study, is really good for looking at soft tissues in the body, but is not that good for looking at, for example, the lung, where there's areas of air, because it's not good for visualizing that. So we always say that yes, imaging is getting more advanced, but it's not the most advanced imaging type that is the best for diagnosing. Okay. And if I give an example, if we're looking for someone with gallstones, for example, an ultrasound is the best study to have. But if we're looking for someone with appendicitis, a CT scan is much better. And then if we're looking for someone who has a muscular injury, then an MRI is much better. So it's all about the right scan for the right patient. And that comes back to the doctor's assessment or the physio's assessment or the clinician's assessment at that time to choose the right scan for the right patient.
Sounds like ultrasound's your favourite. What do you think?
I do love ultrasound, and I love doing procedures with ultrasound as well.
Do you?
And it's just because of that dynamic way of doing things, and it's absolute safety.
Yeah, because when you're in an MRI, you're not moving, are you? You're stationary for so long.
Yeah.
And the body's different when it's moving, but when it's still, you can pick up different things. So that makes sense, doesn't it?
Exactly.
Yeah.
And when I report MRIs all the time, but when I had an MRI myself, it changed my perspective completely on referring someone for that scan.
Yeah.
Because it's very claustrophobic. It was loud,
yes.
and it took a long period of time.
Yes, it does. Yeah, I agree. Okay, so in the UK, I was trained to really prioritize clinical assessment. So part of my role as a physio was assessment heavy. And conservative management was advocated before imaging, because the main thing we were taught was in my profession was, unless you're a surgical target, you shouldn't be requesting imaging, really. Okay. Because it doesn't always improve outcomes. And you mentioned before that it can cause worry and stress and things like that. So what is your view on that? So requesting scans that don't, and do you agree with that? Do you think they should be a surgical target? Like, for example, I'm not a doctor, but as a physio and as a consultant, would you expect other staff to be requesting scans only if they're a surgical target? And also, when is it appropriate and when it isn't?
Okay, so it depends on the healthcare system that we're in. So both of us have worked with the NHS, and in the NHS, resources were slightly limited. So what we didn't want to do was have loads of scans that need to be done, which increases waiting lists for patients who really need that scan.
Yeah.
So that decision is slightly different. Mm-hmm. Now, if we were in a different healthcare system, for example, here, a lot of people have health insurance where they may find it easier to go and get a scan, then the threshold for requesting a scan might be slightly different.
Okay.
But I'm clear that there should be a question that needs to be answered from that scan. Now, sometimes that question is nothing wrong? So say, for example, someone might have a niggling pain and you want to reassure them that there isn't anything serious. Mm-hmm. In the NHS or in a government healthcare system, we might not do that because of resources, but we may do that in a different setup because someone is able to have that. And there is some benefit in having a scan that says nothing's wrong. But at the same time, we also have to be aware that when we do scans, it may pick up something that has no impact on that patient, just a random finding that they then start to worry about.
Yeah, yeah.
And I take the example that if we just went out onto the street and picked 100 people and scanned their spine, for example, we'd find loads of people with a disc problem.
Yeah.
They may have no back pain at all.
Yes.
But if we told them they have a disc problem, they would start worrying about that, thinking, do they need to do physio? Do they need to have an operation? When actually it has no impact on their life.
Yeah, no, 100%. I agree with that. And I think you're right in saying it depends where you are as well. In the UK, a lot of it is it going to change the management? Is it going to change the management? And most of the time it's not going to. So that's why we concentrate more on conservative management. But here, like you said, with insurances, there's a lot more, money, that sort of thing. You can be a bit more lenient with requesting a scan. Yeah. But what do you think about reassurance scans? So in the UK, I'd have a patient who would, do all the physio, do everything right, but they still weren't getting better, and they would want a scan.
Yeah.
So I did at times request a scan because I requested it because I thought, let's see what's actually going on. But I knew it probably wouldn't be a surgical target. But anyway, we don't know everything. So requested a scan, and then for them, they got that reassurance, and then they kind of stopped coming back to clinic, and they were like, okay, fine, I know now. What do you think about reassurance scans?
Yeah, so from experience of reporting scans, sometimes you'll have patients who have very severe symptoms and nothing on the scan. But sometimes we don't think something's going to be there clinically. We think something's not going to be there, and then we end up picking up something.
Okay.
So I think when it gets to a stage of it actually helping the patient, because I do think if a patient's been down a pathway of having pain or having a certain joint issue and not having an answer, ruling out that something is not there I think it's actually a good thing to do.
Okay.
Because it psychologically it reassures them that they can get on with things. So if it's a sports person and they're worried about carrying on with sport because they will make that injury worse, by telling them that actually no, there's nothing serious there, you can carry on with sport or you can carry on with your normal day-to-day activities, that's much better for their overall well-being. So I wouldn't recommend having everyone just having scans. But if someone has symptoms, which there might be a slight percentage that there's something there, I think it's warranted to have a scan. And like I said, resources were different in the UK, but we're slightly more lenient here in Qatar about this.
Yeah. No, I agree. So for me personally, my dad got diabetes in his 30s. And I remember him saying something to me. He said he just felt really thirsty all the time. and he would drink Coke to try and quench his thirst. Obviously, it's not a good idea, but he didn't know. And what happened was he was diagnosed with type 2 diabetes. So as we know, with type 2 diabetes, there's not that many symptoms. There's actually no symptoms early on. Things like high cholesterol or even high blood pressure, there's no symptoms. And because diabetes killed my father, I always think of it as a silent killer because it didn't have any symptoms for ages. So I'm a little bit obsessed with prevention. And I do believe prevention is better than kind of having a problem there. So for me and my husband, I'm always like, let's get our yearly bloods done. Let's try and do things to prevent things. But then I do agree that it can cause health anxiety. Yeah. So what do you think about prevention and then relating this to imaging or investigations like screening, MRI scans? Should we be doing it, and what level is healthy and what level isn't?
Okay. So I think our generation in particular are very interested in health. I think we've learned from the generation before us, and there's a lot of us gathering data. So I'm not wearing my Garmin watch today, but quite often I'd be wearing a sports watch, which tells me my heart rate and how I'm performing. I personally get a yearly health check and try and get data from bloods because I want to know how my body is performing. And I definitely think that's a good thing from a prevention point of view. Now, as you mentioned, there are screening programs, and some are very targeted. So in your example, you said that your father had diabetes. There might be a genetic component to that. So then you might want to screen yourself a bit more because the risk is higher. And it's same for other conditions where someone might have had a certain cancer in the family and they want to get screened for that. So there are programs like breast screening where people have mammograms. There are lung screening where people have a history of lung cancer, and bowel screening. I know my dad underwent bowel screening. So I think they're definitely very warranted, and in healthcare systems, they are very established.
Yeah.
With full body MRI, when I was thinking about this earlier, I was thinking, would I have a full body MRI?
Yeah.
And the answer is yes, I would have a full body MRI.
Okay.
Because it might pick up a serious problem like an early cancer that could be then treated. Yes. However, I also know that it may pick up something that has no impact on my life and is causing me no pain, but may cause me worry. And the example is it might be a nodule in my thyroid or a nodule in my lung or a cyst in my liver, which then might psychologically cause worry. Now, I think that's the key, that people should know that when they undergo a screening examination, there's a low chance or low probability that it may pick up something serious and you may get early treatment. But there's a much higher probability that it will pick up something, in medical terms we call it incidental, but an unexpected finding that has no impact. And patients should be aware of that, that they're opening the door to a worry and they should be okay with that.
Okay.
That's the way that I see it.
Yeah, I think if you are, like you said, genetic, like I'm at risk of type 2 diabetes. And I think in our culture, we all are really, aren't we? So do you think the yearly bloods are a good idea? So if someone's listening, they're in their, approaching 40s, their parents have type 2 diabetes or something like that. Would you advise to get your yearly bloods check and see, HbA1c levels and your cholesterol levels? What would you say about that?
I advise that if you have access to having those bloods done, I definitely advise having that done. And I personally had a health check last year and my HbA1c was slightly on the higher side. Yes. And what that did is it prompted me to live a much healthier life. Yeah. So if I go back 1 year and I look at my lifestyle over the last year purely because of that one blood test, that made me think, actually, I need to fix what I'm doing and cut out certain things. Yeah. So there's one thing is just understanding yourself, but two is sometimes doing that screening can prompt a complete behavior change in that person and can push them towards preventative medicine because you know something that you didn't know before. Exactly.
And I love that because it's not about finding a problem, worrying about it, stressing about it. It's about, look, things are going to happen. Things are going to go wrong. But the sooner we pick it up, we can start to, create a behavior change. So I've got a little bit of high cholesterol. So I'm trying to do things to help reduce my cholesterol. My husband was a bit like you, actually. Last year, he got his HbA1c done. It was slightly raised. So we put some interventions in place, having a high protein breakfast. He got his bloods done again and he's reversed it. So it's a really good outcome measure, isn't it? To see, if you're on the right lines. But what about someone who doesn't know? I mean, we're in the medical field, so we know a bit about it. But what about someone who doesn't know anything about the medical field? Like, do we want to raise panic? Should they go when they have symptoms, or should they start to kind of understand, when to get bloods? What do we say to that person?
Yeah, I think someone who is not on a personal health journey, then definitely going and just getting investigations without a real reason can cause more worry. And I'd say for that subset of patients, it's better to live a healthy lifestyle, how they feel they're living a healthy lifestyle, but only get investigations when the doctor requests that. So that might be that they have a certain pain or they have a certain symptom and there's a reason for requesting those bloods. Because what I've seen over recent years, we used to say Google Doctor, now it's kind of ChatGPT Doctor is the new age of that. And what happens is people will think to themselves, okay, I want to go and get these investigations done. It might be a blood test, it might be an ultrasound or a CT or anything else, any other investigation. And then instead of letting the doctor interpret that, they'll say, okay, what I'm going to do, the doctor told me this, but I'm also going to put this into ChatGPT, and then it tells me this, and I'll actually put the scan directly into AI and ask it that question. And then that can cause multiple different outcomes from what they think is going on and can cause more worry. Yeah. So I think if someone is aware of their health and is monitoring things and measuring things and doing things in the correct way, then I would recommend that. But the interpretation and advice should come from someone who is experienced in the medical field and can look at the whole picture rather than just kind of taking it as one snapshot reading or one snapshot image.
Yeah, no, that makes sense. I think it's clear to say, and we'll agree on this, I think that Qatar is a lot more lenient when it comes to investigations and scans. I mean, I worked in the NHS for nearly a decade, and having been a patient there and also worked there, it is a struggle to get these investigations and preventative scans and things like that. So for example, for me personally, I was getting pain on my left side in 2018, and I went to A&E 6 times. And they kept saying, oh, it's renal colic. No investigations were done. I had some bloods and they came back normal. But cut a long story short, after my 6th visit, they'd have finally referred me to urology because they were barking up the tree of it's renal colic, it's renal colic. But when they finally did do an MRI or a CT scan, actually, they found that I had a 13 centimetre ovarian cyst on my left ovary and it caused a torsion. I was so angry because I had to have major surgery to have my ovaries removed, and it was major laparotomy surgery. Yeah. And it still plays on me that, if somebody had just done a CT on my first or second visit, I could have saved my ovary. And it was just so frustrating. So I think it is a shame the way the NHS is, because there's a lot of pressure and things like that. But I think pain is an indicator that something might be wrong. And I think if it's not got better after a certain time, then a scan is warranted. What do you think?
I agree with that. And in defense of my doctor colleagues, we have a saying that common things are common.
Yes.
So when someone comes in and they have a certain pain, they will look to see what the most common or the normal thing that causes this. And often that is not something serious. And that's often why imaging investigations or bloods or any other investigations aren't carried out immediately. But there are times where something serious is going on. And what I'm seeing in practice across the world is that as scanners are getting better, and that might be CT scanners, MRI scanners, ultrasound, everything is getting better and also getting faster and more efficient and lower radiation. It means that more scans are being done.
Okay.
So, for example, as a radiologist, we've never been in more demand because more and more scans are being done. And I think that, so the ease of having investigations will probably get better as time goes on, and it's to prevent things like that, a misdiagnosis that leads to something serious.
Yes. And how often do scans find abnormalities in healthy people? Because I was a healthy person. I turned up at A&E, no medical problems, really healthy, running, exercise. How often are abnormalities found in healthy people?
So age definitely has an impact on this. So if I take an example of my father, he's in his 80s. If he had a scan, almost certainly there would be lots of things that we would find on that are completely unrelated to anything from his health. Because I give the example of my car. My car's gone to the garage today. If I asked the mechanic to do a full inspection of my car, I'm sure, because my wife's normally driving that car, that there'll be loads of scratches, particularly on the rims around the car. But that doesn't have any impact on actually how the car drives.
Yeah.
And I don't have to replace or fix
I see what
those
you mean.
things.
It's got to change
for life
the
to go on.
management. It's still
just
functional.
it's just the wear and tear
Yes.
of the car. And that's the same in a patient. So in the older age group, it's very common to find things wrong on a scan that don't have an impact on that patient. In the younger population, it's less common.
Yeah.
But you do see these wear and tear things that are happening with patients. So it's not unusual to see, for example, a disc problem in a young patient who might be, for example, a gym goer or lifting heavy weights or have a certain job where we'd find that, but they don't know about it and there's nothing to worry about.
Okay.
But if someone comes in with a symptom, then I would say it's almost a kind of 50-50, but it's okay for a scan to be normal. That's what I say. It's okay for a scan to be normal and for someone to go home knowing that nothing is wrong or nothing serious is wrong.
Okay. So age plays a factor. So the older we are, the more, do you think the older we are, the more we need to be a little bit more health aware or health kind of, health awareness of our health and things like that? So what about someone who's aging, what about things like DEXA scans that can pick up things like osteoporosis? Do you think they should be kind of routinely done?
Yes, so DEXA scan is another one alongside the full body MRI that more people are getting done because there's lots of benefits to a DEXA scan. One is looking at bone density, and this is much more common, for example, in postmenopausal women where there are hormonal changes and osteoporosis becomes more common. And that means that they're at risk of getting fractures from minor injuries.
Right.
Now, again, in the same way that we spoke about interventions for us having a high HbA1c, there are interventions that can happen for someone who might be having osteoporosis. And that could be through medication, through lifestyle factors, through exercise. So I definitely think that in certain scenarios, it's good to have those scans.
Yeah.
The other thing with DEXA scans is that fitness gurus are doing is it's good at looking at body fat percentage as well.
Okay.
So if, for example, I was looking to get a six-pack, I know that I need to be below 12% body fat.
Yes.
And the most accurate measure of that is through a DEXA scan.
I didn't know that.
Yeah, so
I
there are
really didn't know that.
young patients, especially people who are really into fitness, who will go and get regular DEXA scans to look at their body fat percentage.
So I thought a DEXA scan only looked at bone density, but it looks at...
so it looks at overall body composition.
That's so interesting. Okay. And let's talk about the effects of these scans then. So with X-ray, there's radiation. How much radiation is there? And then the things like DEXA scans, MRIs, do they have any forms of radiation? Like how dangerous are they or exposure to them?
So if we split the scans into two sides, so scans that have radiation and scans that don't have radiation. So the ones that don't have radiation are ultrasound and MRI. No radiation associated with those scans, so you don't have anything to worry about. Then if we take X-ray, CT and nuclear medicine studies, which is like a PET scan, these all have associated radiation. If you take just an X-ray, I think that there's nothing to worry about. And the analogy that I use for comparing the radiation dose is the radiation dose of an X-ray is similar to a flight from Doha to London. Now, I wouldn't think twice about flying the family back this summer. And for that reason, I wouldn't think twice about someone having an X-ray.
So an X-ray is like taking a flight?
Yeah, an X-ray is similar to the radiation from taking a flight or eating some Brazil nuts or even the background
Brazil
radiation.
Nuts?
Yeah.
Okay, so hold on. You're telling me that flights and Brazil nuts cause radiation because I love flying and I do like Brazil nuts. So what's going on there?
Yeah, so just from living in Qatar or living in the UK, there's a background radiation that comes with that, and flying, certain foods have radiation. So, but these are very low doses and don't have any impact on your health. So that's why I use that analogy, because people might be worried that an X-ray has radiation, and then when you compare it to something you wouldn't think twice about, then you think to yourself, you don't need to worry about having that X-ray. The problem comes where people are having a series of X-rays. So say, for example...
Well, I've had a series of holidays. Yeah. So is that I've not had a series of X-rays. So what's that going to happen? What's going to happen to me with that then?
So probably then it still wouldn't cause a problem.
It wouldn't. Okay.
But with X-rays, the only time where I am a little bit more concerned about someone having a series of X-rays is if it's a very young child.
Right.
So specifically in babies, because they're still developing at that stage.
Okay.
So their sensitivity to radiation is slightly higher than an adult. But just in general, if I had an injury, my wife had an injury, my son or daughter had an injury, and I was worried, I wouldn't think twice about having an X-ray done.
Okay. So it's not that dangerous then. It's quite safe. Okay, fine. Okay, good.
But then if you move on to CT scans, this is like having a series, so hundreds of x-rays in one go to build a 3D image. So the radiation associated with that is higher, but a single CT scan is not too worrying. But again, a series of CT scans over a short period of time can have an impact on health. And the risks we're talking about are, one, inflammation in a certain area that can happen if you have multiple scans, and then a long-term risk of cancer if you're having very, very, like a high number of scans.
Okay.
But as time goes along, scanners are getting better.
Yes.
Radiation is reducing.
Okay.
And for that reason, we worry less and less. For adults, the subset population is pregnant ladies or ladies who are breastfeeding.
Okay.
Because one, the fetus is more sensitive to radiation, and breastfeeding, lactating breasts are more sensitive to radiation.
Okay.
So these are two areas where we're slightly more careful.
A bit more cautious. So most people think radiologists only read scans, but your role is very interesting. It's an interventional radiologist, so it's a bit different. Can you explain your role?
Yeah, so I trained as a radiologist, so I interpret scans, but then as a kind of subspecialization, I became an interventional radiologist, which is where we use image guidance to perform procedures. And the way that I think of myself is like a plumber of the body. So we have lots of tubes in the body. We have our arteries, we have our veins, we have bile ducts, we have we have tubes that go from our kidneys to our bladder. And I can get into any of those tubes through a tiny hole, and I can block that tube, I could unblock that tube, or I could deliver a therapy to that. So if I give an example of just yesterday, yesterday we did a cancer treatment for someone who had a liver tumor, where we went directly into the blood supply for that tumor and delivered chemotherapy directly to that tumor without causing any side effects to the rest of the body.
Oh.
And then last night I was in because someone had bleeding from their bowel, like significant bleeding from their bowel. So we went into that blood vessel and blocked that blood vessel to stop the bleeding. And the incision was less than a couple of millimeters.
Wow.
So this is the amazing thing about the advances in medicine, where
I didn't know chemotherapy could be delivered like that. I just presumed that you would be attached to a drip and deliver chemotherapy, but you actually go directly and target, like, for example, that was it the liver you said?
Yeah, the liver. Yeah, exactly. So this is where medicine is moving forward at a rapid rate, and changes are commonly happening. And what I'm often saying to patients who are being referred for surgery is think about the most minimally invasive option. So that patient I treated yesterday will go home today, but if they had a surgery to cut out that tumor, they would be in hospital maybe for a few weeks. Or maybe a week before they go home, and they'd have a long recovery, while this person would get back to normal function within a very short period of time. So we're always looking to see what are ways we can carry out things that are minimally invasive and not major surgical procedures, but would have previously had a surgical procedure.
And that clearly work really well and help the patient.
Exactly.
Yeah, that's amazing. So in the UK, I mean, I did minor surgery, we could call it, but I used to administer steroid injections to patients for different health problems, so like particularly osteoarthritis, frozen shoulders, just basic steroid injections to the soft tissue or the joint. These were done landmarked without any imaging, but some of the steroid injections did need to be done under ultrasound guided, like a hip intra-articular injection. What do you think about doing kind of these minor surgical procedures landmarked without imaging? Are you for like, nope, do them for imaging? Because some of the doctors that were in my department were like, all your steroid injections should be done image guided, but I wasn't trained in image guiding. So for example, a carpal tunnel syndrome, I would do it landmarked. But then some of the doctors were like, the sports and exercise medicine doctors were like, you should absolutely be doing that ultrasound guided. What's your view on doing these procedures not guided, ultrasound, or not image guided?
So I'm biased the other way because I was only trained in doing image guided procedures.
Yes.
So all injections and all needle placements are always done under image guidance. But my take on this is that experience matters.
Yeah.
So if you have someone who's done landmark procedures for 20 years, often these doctors or physios or practitioners are excellent at doing that, and they've become very good at doing that. If you ask that person to suddenly swap to image guidance, their outcomes might not be as good. But the difference from my side doing image guided injections, for example, is that we can look at an MRI scan. Say, for example, you give the example of a hip, and you might say that specifically this bursa or this area is where the inflammation is. And then under ultrasound, we can say, okay, this is where that area is, and this is exactly where we're going to place our needle, and we're going to inject the anesthesia or this steroid, which is very difficult to be done based on landmark, not because of skill set, but just because you can't focus on that specific area.
I see. Okay.
But the volume of patients that need injections or need procedures is very high across the board if you take the UK or you need Qatar. And if we said every single injection needs to be image guided, I worry that the waiting times for those injections would be out of control.
Yeah, I agree. And resources are used that don't necessarily need to be used. And I think, is there a safety element as well? Because obviously with the hip, because it's so deep and there's artery and the structures there, that's when it would be more appropriate to have the images guided for safety as well.
Yeah, exactly. So there's certain scenarios we'd say, okay, it's compulsory to have an image guided injection. And there's certain scenarios where you could say you could have it landmark based or you could have it image guided. And then it's down to the discretion of the patient what they feel is better. I'm probably biased one way towards having an image guided injection.
Yep.
And I take the example of a family member who recently asked me that they need a knee joint injection. Should I have it image guided or should I have it landmark guided by the surgeon?
Yeah.
I said image guided, but I have a bias towards that.
Yes. Yeah. Okay. Fine. Okay. So when is the absolute need to have an image or an investigation? Sorry. So for me, when somebody came in for a back pain, for a back problem, we would screen for red flags. And then there'd be certain red flags which would be like, yep, they need an urgent MRI. So we would be looking at things for like quadral equina, saddle anesthesia, bladder incontinence. So what are the red flags? I mean, obviously there's loads of different red flags, but what are your main red flags where you think, okay, this person definitely needs an urgent scan?
Yeah. So often it's sometimes the family physician or the other clinical team that would pick up on these things. In musculoskeletal imaging, you've mentioned the thing that we worry about is when the quadral equina, which is the last part of the spinal cord, is being compressed by a disc. And if that's compressed for too long, that can have long-term consequences of motor function and sensory function. So that's an emergency. And normally when anyone has even a slight suspicion of that, we say that an urgent scan is required because that would need an emergency treatment. The other time when we see red flags is when clinicians are worried about cancer. Okay. And common scenarios are weight loss over a short period of time, bleeding where they're having anemia. So for example, they might check blood tests and they see that this patient's anemic for no specific reason, or any clinical signs that might point someone towards a cancer. So if I say a lung cancer, they might be coughing up blood. For a liver cancer, they might become yellow, or jaundice is the term that we use. So there's certain times when we're worrying about cancer where we say to do a scan, and in each category of medicine we have red flags. So for MSK we have red flags. For the heart we have red flags.
Okay.
And often it's the combination of the history, the examination, the blood test, and then putting that all together. The doctor who sees that patient is like, I'm worried about this. And there's an instinct in them that's saying, something's not right and we need to sort this out quicker, rather than putting them on a waiting list, which the scan's going to be done in 2, 3, 4 months. Okay. No, this needs to be done sooner.
Yeah. Is there any scan that you're against and you don't like to use, or you just don't think it offers much value? So
I would say there's not a scan that I'm against, but there are scans that are used inappropriately. So I'm not, for example, a big fan of X-rays outside of the joint. For example, a chest X-ray is, you might say, I've seen chest X-rays which look completely normal, and then we do a CT scan and you can see a big tumor on it because it's hiding behind the heart.
Okay.
So I wouldn't 100% be reassured by just an X-ray if it's to rule out something serious. And sometimes we will do an X-ray for a fracture. We don't see the fracture, but the clinical team is saying, no, there's something wrong. Like this patient had a fall, they can't walk, they're in severe pain, but the X-ray doesn't show a fracture. Then we would say, no, you need to do something else. You need to do an MRI or you need to do a CT, and then you pick up a fracture.
Yes, so I had a patient who came in to see me with hip pain. She was a 22-year-old, she'd just run a 5K. And she could not weight bear on her hip. She went to A&E, they did an X-ray and it was fine. Started her on some physio, painkillers, but it just wasn't getting better. So she actually went privately to get an MRI. And when she had the hip MRI, it revealed 2 stress fractures on the neck of the femur. And we know now that stress fractures, they're not picked up in x-rays. But why do they do that then? Why is the pathway always, let's do an x-ray, if nothing, and then they move on to something else? Like, shouldn't it, like, what do you think about that pathway? Do you think it's a bit dated?
It's, I think it will change in the future.
Okay.
I definitely think that will change in the future. But it's like this low barrier to entry because X-ray is very easily available. It's very quick. It's generally quite cheap.
Yes.
So,
Okay.
for example, in health centres, you may have an X-ray machine. In other diagnostic areas, X-ray is very available in lots of different places. While to have a CT scanner, it's normally the hospital or where you would go for your CT scan. So it's a little bit more hassle for the patient and for the clinician to organise that.
Yeah.
So they would say, okay, fine, we'll do a screening and make sure that there's nothing serious there. Okay, if there's no fracture. Now, that's down to the doctor and to the patient, because I think there's now more and more patient ownership that they should say, I know something's not
wrong.
right.
So, Dr. Rahil, explain to me, why can't you pick up a stress fracture on an X-ray?
The reason why you don't pick up a stress fracture is because this is a 2D image of a 3D structure. And sometimes the resolution isn't good enough to pick it up. And you don't have all the angles. So when we do a CT scan, for example, this is multiple X-rays which forms a 3D image. But you can form a complete 3D reconstruction of that image. So I can look at it we call it in medical terms different planes, but I can look at it looking straight on at the bone. I can look at it looking sideways at the bone. I can look at it at different exactly at all the different angles to see exactly what's going on and to a higher level of detail. And you can look at the surrounding structures as well. And I think this makes a big difference. So a severe fracture, where the bone is completely apart, yes, you'll pick it up.
That up.
But again, if someone had this person who did a marathon, stress fracture is one thing. They may have had some inflammation around the joint, which wouldn't pick things up. They may have had a tendon injury.
I mean, it was a rare condition, and she was taking steroids as she was when younger. So that was, I mean, we don't know, but it could have contributed to it, the orthopaedic surgeon said.
But again, in defense of my doctor colleagues, when you say common things are common, I always come back to that. Common things are common. So
I mean, that is a rare situation. A 20-odd-year-old girl, having a stress fracture. Yeah. So why are they not improving X-rays then? So why is it still at did you say 2D imaging? So why are they not improving an X-ray so that they can see thoroughly?
I think it's because things have moved on. So the example is we're all using AI at the moment. I use ChatGPT and Claude. It's like me going back and saying, okay, when we used to use Yahoo back in the day, why don't they just improve that a little bit when we're already so far ahead on other things? So all the improvements are coming in the new age of imaging rather than in the plain film X-ray. But what happens is medicine technology is moving at a rapid pace, but implementation of all that technology is slow.
So where do you see like medical imaging going in the next 10 years with regards to AI? Where do you think it's going?
So I'm super excited about medical imaging going forward. And that's because where the future of imaging is fusion. We call it fusion imaging. So where someone will have a CT scan, an MRI scan, an ultrasound scan, or they might have a combination of those put together. So for example, they might have an MRI scan and then we fuse it with the ultrasound. And when we do the ultrasound, we can also see the MRI moving at the same time in live pictures. So then targeting treatments is going to be much better. The other thing is speed, cost and availability is going to improve.
Okay.
And also one worry for patients is they have a scan and then they have to wait a week, 10 days for the results. Because it's one misconception is it's the radiologist who reports the scan and the doctor who relays the report. Some people think it's the doctor that saw them that interprets the scan, but that's not necessarily the case.
Okay.
And the backlogs for reporting are high, but with AI coming in, it's making me as a radiologist much more accurate at the reports I'm doing.
Okay.
But also faster at the reports we're doing. So I believe that turnaround times will get better.
Yeah.
And the findings that we pick up on scans will just get better and better.
Okay. Do you think it would result in like less jobs though?
No, I don't think it will actually. So what we found in radiology is AI came in, more scans are being done. There's a higher requirement for radiologists.
Okay.
I think it will result in is the perception that more people have things wrong. So I know something that people have said to me recently is, don't you think more people have cancer now than 20 years ago.
Okay,
Do you
yeah,
not
because
think
is it like 1 in 2 people will have cancer?
But what I think is happening is more people are getting investigated and more cancer is being picked up.
So do you think it was always would you think it was always 1 in 2, but it just wasn't investigated enough?
Yeah, exactly. So I don't know the specific statistic on the pickup of cancer, but the perception that there is more cancer or more other types of disease going on, I don't think is because there's more disease around. I think it's because more is being picked up.
We're getting more
so
sophisticated.
then someone is given the label of cancer or a specific disease. And then in statistics, that's going up. And what we hear about amongst friends is that's going up. So if someone has, for example, in the female population, if they're part of a breast screening program, then they might say, okay, I heard that my friend has got breast cancer, which they wouldn't have heard if there was no screening program, because that wouldn't have manifested until quite a late stage. So I definitely think as more scans are being done, the perception will be that people are getting more unwell, but that's not the truth. It's just that there will be earlier diagnosis and earlier treatment for things that are going on.
Do you think we are over testing then? Or do you think it's needed?
I do think there is an element of over-testing, but I don't think it can be stopped. This is my thoughts on this. And this is the culture of the newer doctors coming through.
Yes.
It's history, examination, bloods, scan. And we say now everyone gets a scan. And I'm thinking even myself was relatively healthy.
Yeah.
Even I've had in the last year an ultrasound scan. I've had x-rays before in the past.
Yeah.
And if I just in my immediate circle as a close family, I can think that they've had imaging investigations done. So we do a lot of scans. It will cause worry.
Yeah.
And that's probably the key point here is that imaging is amazing at diagnosing and picking up things that can go wrong with the body, but it's also amazing at picking up things that are present in your body but don't cause you any harm at all. And that, I think, is what the listeners need to be aware of when they're going for a study, and to be able to manage that concern that comes with that.
So what would you say to someone who, because I agree with you, I'm all about prevention. I think it's important to go for a yearly checkup, to be health aware, health conscious. And I think on social media, it's so good that everyone's into this wellness and everyone understands like what foods to eat, what things to do, because there's a lot more research, investigations are more sophisticated, just like you said. But what about someone who's just burying their head in the sand? They don't want to know. They know their family's riddled with type 2 diabetes, they've got cardiovascular disease in their family or cancer, but they just don't want to know. What would you say to that person?
I come back to the point that you started with. Prevention is better than cure. So if someone has an awareness that they might have something wrong, I think it's better for them to get investigated. And that might start with just visiting the doctor. It doesn't have to be like a complex MRI scan of their whole body or anything else from that point of view. But they should try and make themselves aware. And I think we come across the two spectrums of people who are super healthy and maybe take it too far in one direction, and then we have the opposite spectrum. We have the opposite spectrum of people who are completely burying their head in the sand. And ideally, what you want to be is a healtry medium
in the middle.
So you're living a healthy life, you're enjoying life. Sometimes it's okay to have like unhealthy aspects of your life just for enjoyment, but you have an awareness of both sides. And if something is a trigger, and I say the male population is really bad for this, for leaving symptoms till the last minute. So it's very common for male patients, for example, to have long-term weight loss or long-term pain and not to get investigated because it's just it will be fine, and then present at a later stage. That's much more common in adult men than it is in women. I think you've made a really good point there, actually. So it's about having that middle balance, isn't it? So not being overly conscious, but kind of being somewhat conscious so you can do things about it. Because it's not about avoiding every disease or every problem. It's about understanding things and trying to improve the quality of your life as much as you can, isn't it? Yeah. I think all of us are aware that health is wealth.
Yes.
So there's no point in having millions of pounds, but not being able to enjoy it.
Oh, I agree.
So the main investment in ourselves, I think from a health point of view, is making sure that we're healthy for ourselves and healthy for our children as they grow up. So I want to be able to play football with my son when I'm 50 or 60. And I suppose that's one goal. And through that, all of this comes into it. And even through the previous conversations that you've had, it's about being healthy, but also having an awareness of your health.
Awareness,
so anything that is measured can be improved. And in these investigations, sometimes it's used because something's wrong and you need to get the diagnosis to get it fixed.
Yeah.
And sometimes nothing's wrong, but you just need a measure, but that just needs to be used in the correct way.
Yeah. Yeah. No, I agree. I think awareness is definitely the first step, isn't it? To be aware of things and then to start to think, okay, how can I investigate this or look at this? And for me, it was my father's inspired me to do this, because his health journey is not something that I want to be more aware. I think my dad was like, live each day till it's your last. He was he was full of life, but I think with regards to his health, he just buried his head in the sand. He knew, and he was a very clever man. He was a very intelligent man, but he just kind of buried his head in the sand. So I think there was a lot of people like that. So what would you say to the clinician who is struggling to understand when it's appropriate to request a scan or not? So I think in my field personally, from a physiotherapist practitioner, we were always kind of, weighing up the patient, the cost of the NHS, what our managers are saying. Like, what do we need to say to clinicians about requesting scans and when it's appropriate and when it's not? What would you say to the clinician?
Okay, what I would say to the clinician is, if your gut feeling is that something is wrong, then it's okay to request a scan. And then the second thing I would say is that the general perception among the medical or healthcare community is that radiologists just sit in a dark room and don't want to talk to anyone. But actually, radiologists do like people coming to speak to them. Radiologists do like cases being discussed with them. So it's okay in selected cases, if you're concerned about something, to pick up the phone to the radiologist and say, look, this is going on. What's the best thing that could be done? And they might say to you, actually, I know you've requested an MRI for this patient, but I'd prefer a dynamic ultrasound so I can see exactly what's going on. And I think those conversations are good to happen.
Okay. And as long as they can clinically justify it, yeah? So if you can clinically reason anything, you can pretty much get anything.
And my threshold for ultrasound and MRI is lower because there's no associated radiation that comes with it. The other thing, so there's two things with CT scans in particular, is one, the radiation dose, but two, also quite often you have X-ray contrast that goes with that, which is a dye that is injected into the vein to try and highlight certain structures. Now, in patients who have kidney problems, that can have an impact on the kidney as well. And there's a risk of allergy in that scenario as well. So I have a slightly lower threshold for MRI scans and ultrasound because there's no associated risk with that. But then it's just about resource allocation.
And costing of it and things like that,
costing
isn't it?
and resource allocation, exactly.
Okay, fine. So, Dr. Rahil, if you could give one piece of advice to the listener about scans and medical imaging, so your final piece of advice, what would it be?
My final piece of advice would be, for the general population, if you are referred for a scan, I would ask your doctor, what question is this going to answer? And how is this going to impact the management of the problem that I'm having? And if they can answer both of those questions, then I think it's good to go forward and have the scan. If they can't justify either of those questions, then I would question having the scan.
Okay. Amazing. Well, Dr. Rahil, thank you so much for sharing your knowledge. Wow, that has it's blown me away, actually. I've learned so much from this, and it's cleared up so many of my own questions. And I really think the listener will benefit from any worries or concerns they have about scans. So thank you so much.
No, thank you so much for having me on the pod.
No, you're welcome. Thank you very much for listening to the Health Diary podcast. And that was an exceptional episode, and I hope you benefit from it. I'll see you on the next one. Take care.